quiz, which was for the first segment with the students and second segment with the technicians. Ladies and gentlemen, we are just a couple of minutes before we commence the proceedings of the academic deliberations of day 2. That's in principle already in motion with the quiz just got concluded. Professor Chaudhary would be declaring the results and the winners would be felicitated during the closing ceremony this afternoon. We're just waiting for the arrival of one or two of our panelists. We hope to have them in the next couple of minutes and then we'll get going. Probably since there's been a quite wild evening last evening and the delegates are having a toll on themselves as a cascading effect. Nonetheless, we'll get going and we'll just be back in another 2 or 3 minutes. Thank you very much. Please start settling down. In the meanwhile, we have enough time to request all the speakers of the succeeding sessions, including the first session, to please load the presentations at the preview desk.
Chairperson, panelists, and dear colleagues. Myself, Dr. Ayush Shukla, Assistant Professor in Department of Cardiology, KGMU, and I have been allotted this topic, newer calcium channel blockers looking beyond blood pressure control. So, as the saying goes, that the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. This was said in 1931, but then the data evolved, and now we know that hypertension coexists in 7 of the 10 patients with first heart attack, 8 of the 10 with first stroke, and 85 to 95% of chronic kidney disease, stage 3 to 5, there is hypertension. We also know that CV mortality risk doubles with each 20 by 10 millimeter of mercury BP increment, and management of hypertension significantly reduces the cardiovascular events, be it stroke, infarction, or heart failure. So, now multiple drugs are present to control hypertension in this era. Calcium channel blockers are most commonly used for the management of hypertension. And of them, there are 2 main classes, dihydropyridines and non-dihydropyridines. Dihydropyridines are selective for vascular smooth muscle cells, while non-dihydropyridines have greater selectivity for cardiac myocyte. So why calcium channel blockers? Because in all trials to date, the group with best BP reduction achieves best outcomes. But there has been an exception, and in this accomplished trial, over 11,000 patients, ACE inhibitor plus calcium channel blocker had 20% CV risk reduction compared to ACE inhibitor plus diuretic combination. And benefit of calcium channel blocker also extended to slowing CKD progression. And thus, in various algorithms for treatment of uncomplicated hypertension, be it hypertension with CAD or with CKD, we find CCB as a major holder. In the history of calcium channel blocker, in 1960s, this concept developed by Fleckenstein that drugs can block the entry of calcium in the myocytes. Then Gottfried is a major scientist in calcium channel blocker, and he and his associates showed that effects of diphenylpiperazine analogs in preventing agonist-induced vascular smooth muscle contraction could be overcome by antagonizing the concentration of calcium in extracellular medium. Verapamil was developed in 1962, and in late 1980s, therapeutic application of CCBs occurred. Now, this is how the calcium channel blocker acts. The drug attaches to the alpha-1 subunit most commonly of the L-type calcium channel, which reduces the influx of calcium ions into the intracellular matrix, thereby inhibiting the vascular smooth muscle contraction and reducing the heart rate, reducing contractility as well. And when it acts on other channels that I'll tell, it reduces the sympathetic outflow as well. So the different types of calcium channels that are available and known are L-type, which is long-lasting but absent in renal tissue, mainly found in cardiac and vascular tissues. Then the N-type channels, which are also present in renal tissues, and they initiate the neurotransmission by releasing norepinephrine from peripheral sympathetic nerve endings. Then there are T-type channels, which are transiently activated, and they are present in renal tissues. Then the P or Q types, where they are neuronal type of calcium channels, and they were recently detected in arterioles. So these different types of channels, of which L-type is the main and the most common, which is known. But the L-type blocking, or the L-type calcium channel blockers, does not cater to some needs, and they are the short-acting and lack of T calcium channel blockade on SA node reduces baroreceptor sensitivity. Reduced baroreceptor sensitivity leads to increased sympathetic activity and reflex tachycardia, and increases the BP variability. So once this was identified, the further calcium channel blockers were developed, and the third generation and fourth generation, some are amlodipine, lercanidipine, azelnatipine, and latest is cilnidipine. The benefit that third or fourth generation calcium channel blockers offer over the previous generation is that there are additional channel blockades in addition to L. There is N channel blocker, there is T channel blocker. The onset is slow, the strength is strong, the duration is long lasting, and there is renoprotection as well. There is no sympathoexcitation, well tolerated, half-life is a bit shorter, and lipophilicity is increased. Thereby, the side effects of tachycardia and edema are less. Some points about amlodipine pharmacology. It is an extremely slow-acting drug which takes about 6 hours to act. Hence, it does not have negative inotropic effects. It also inhibits potassium channels, and higher concentration of amlodipine used over a long period cause reflex tachycardia. Then came azelnatipine, which is an L and T type calcium channel inhibitor, thereby being highly vascular selective and lipophilic, does not cause reflex tachycardia, has also shown to have some anti-inflammatory, antioxidative, and free radical scavenging properties. Talking of cilnidipine, it is an L and N type calcium channel blocker with equal affinity. Inhibits the sympathetic nervous system, causing no reflex tachycardia. So it is also drug of choice for white coat hypertension and morning hypertension. It has a better anti-ischemic action, favorable glucose metabolism, also shown to improve LV function, and least of the side effects. So this is the relation of N-type calcium channels to major complications of hypertension. This sympathetic overactivity that happens due to activation of N-type channels leads to platelet activation, increased cardiac oxygen consumption, tachycardia, increased oxidative stress, and activation of RAS, thereby leading to all the complications of hypertension, that is stroke, MI, angina, heart failure, and CRF. Some data about azelnatipine and cilnidipine. These are the latest of the two drugs, so I will be focusing on these. Effect of azelnatipine on glucose tolerance, insulin sensitivity, and inflammatory state. Small study, but it was found that when compared to amlodipine, although the BP level reduction was identical, the heart rate significantly decreased after azelnatipine administration, and compared with amlodipine administration, azelnatipine significantly decreased levels of glucose and insulin after 75 gram of oral glucose tolerance test. Azelnatipine also reduced morning BP and pulse rate in this home study, and early morning BP control, we know, reduces risk of CV events. Azelnatipine has also shown to reduce sympathetic nerve activity, reflex tachycardia due to T calcium channel blocker. So the advantages of azelnatipine over amlodipine was that there is better morning and ambulatory BP control, there is better cardioprotection, and anti-atherosclerotic effect, reduced arterial stiffness, improved endothelial function, and better cardioprotection. Talking of cilnidipine, the latest, the fourth generation, and the cardio-reno-neuroprotective calcium channel blocker. Again, there are studies which have proven that there are changes in urinary 8-hydroxy-D-glucose and L-fatty acid binding protein, which are markers of oxidative damage and renal tubulointerstitial injury, respectively. So cilnidipine vis-a-vis amlodipine has shown better reduction of these markers. It is also superior to amlodipine in preventing progression of proteinuria in hypertensive patients when coupled with a RAS inhibitor, and various subgroups, whether age or sex or BP after 12-month treatment, diabetic nephropathy, the antiproteinuric effect was superior in cilnidipine group compared with the amlodipine group, even in different subgroups. Also, there is change in glomerular hemodynamics better than amlodipine in the cilnidipine group. It improves the effective renal plasma flow and glomerular hypertension without worsening the total renal function. In talking of Indian data, cilnidipine has reduced albuminuria in Indian hypertensive diabetic patients also. This chart we can see baseline after comparison with 6 months of cilnidipine treatment. Albuminuria is reduced better than amlodipine. Similarly, in arterial stiffness and central aortic pressure, cilnidipine has proven to be superior to amlodipine. Also, LV function parameters, the tissue Doppler imaging, tie index at baseline and after 2 months treatment with cilnidipine. So after treatment, tie index was significantly decreased. Now, once we have arrived to this conclusion that azelnatipine and cilnidipine are somehow better than amlodipine in although small studies. Is there any data vis-a-vis both comparison of Azelnatipine and Cilnidipine? There are some studies, and in this we can see that Azelnatipine has proven a slight edge over Cilnidipine in patients with heart failure with preserved ejection fraction. There are two small studies in which this effect of switching from Cilnidipine to Azelnatipine on cardiac sympathetic nerve function in patients with HFpEF, there Azelnatipine improved the dysfunction of cardiac sympathetic nerve activity compared with Cilnidipine in patients in these patients. But when we talk of albuminuria and CKD effects, Cilnidipine is more efficient in reducing albuminuria than Azelnatipine, independent of its BP lowering effect. So to summarize my talk, the newer calcium channel blockers offer benefits beyond BP reduction, and that is in the form of cardio-reno-neuroprotection. Amlodipine, being selective L channel blocker, lacks in providing these additional benefits. The Azelnatipine has additional advantage over others in providing benefit to patients with HFpEF. Cilnidipine has proven its advantage in reducing microalbuminuria and diabetic hypertensive, and both the agents reduce reflex increase in heart rate. I rest my talk here, and I'm open to questions, if any.
Can you give
Channel blocker. And the T-type channels are mainly present in the renal tissue and also in the sympathetic nervous system. So once the T channel is blocked, we do not get that kind of reflex tachycardia that is with the only L channel blocker.
good
And I think, thank you, Dr. Ayush, for wonderfully explaining us the various effects of moving beyond L-type channel blockers to N and T types of blockers. And if I can summarize Dr. Ayush's talk, then there are three major benefits of using these newer CCBs. One is reduction in proteinuria. Second is reduction in reflex tachycardia, rather decrease in the heart rate, especially in a young patient if you are looking at who is having tachycardia. And of course, last but not the least, reduction of P-delta. But the only thing which we probably are lacking are cardiovascular outcome trials, but I don't think we need them because once, as Dr. Ayush said, BP is reduced, then cardiovascular outcomes are going to improve. So these are probably pleiotropic CCBs, you can say like that they have extra advantages over and above amlodipine. Any comments from our panelists?
So with the current data, I think that Cilnidipine newer calcium channel blocker should replace amlodipine.
Yes.
Okay, that's the.
But there are studies, sir, where amlodipine, who are in favor of amlodipine, have also said that amlodipine also has some T and N channel blockade also. It's not an isolated L as it is proposed.
Okay, that's the time that we have with the permission of the chair. Thank you very much, Dr. Shukla.